Hello, and welcome to this Practicing Clinicians Exchange podcast. I'm your host, Nicole Mitchell. This is the first of a three-part podcast series based on the webinar, The Biggest Risk to Cardiovascular Health, Addressing Social Determinants of Health and Non-Valvular Atrial Fibrillation. Faculty for this webinar included Dr. Keith Ferdinand, Professor of Medicine at Tulane Heart and Vascular Institute and Tulane University School of Medicine in New Orleans, Louisiana; Dr. David Kountz of Hackensack Meridian School of Medicine in New Jersey; and Laura Ross, President-elect of the Academy of PAs in Cardiology and a PA at the Park Nicollet Heart and Vascular Center in Minneapolis. In today's episode, Dr. Kountz discusses specific social determinants of health that impact NVAF care and examines the impact of these social determinants on NVAF CV-related outcomes. For more information on Dr. Kountz and all our faculty, along with a CME CE certified on-demand webcast for downloadable slide sets and a clinical thought commentary, please visit pce.is/NVAF. Now, let's get started and hear what Dr. Kountz has to say regarding social determinants of health to consider in patients with NVAF and how these may impact NVAF CV-related outcomes.
And with that, let's get started. It's my great pleasure to turn things over to our first presenter, Dr. Kountz. Thank you for being here today, and I'm excited to hear your perspective on social determinants of health.
Thank you so much, Laura, and hello, everybody. So we're going to begin with a case, and I'd like you just to think about this patient as we go through our rest of our presentation. It's a middle-aged African-American woman with uncontrolled hypertension and type 2 diabetes. She's obese with a BMI of 38. She has noted palpitations and weakness on a recent exam. Her ECG shows atrial fibrillation. She was started on warfarin, but had wide variations in her INR. And she was given a prescription for rivaroxaban, but it wasn't covered by insurance and never filled. And I'm sure many of you have seen patients like this and can relate. And we'll come back to her near the end of our discussion today. So atrial fibrillation, just to level set for all of us, is the most common cardiac arrhythmia, with nearly 60 million adults worldwide suffering from this condition in 2019. Atrial fibrillation is associated with a number of significant outcomes, both cardiac and non-cardiac, including cerebrovascular disease, myocardial infarction, frailty, cognitive decline, and high healthcare utilization. And as we're learning with many conditions, social determinants really contribute to many of these poor outcomes, contributing related to recognition, evaluation, treatment, outcomes of diverse disease states, limited examination in atrial fibrillation. So we're going to quickly go around this cartoon showing the overview of social determinants. Remember that only about 20% of outcomes are related to healthcare delivery. The remaining 80% relate to various social determinants. So it's a huge issue, and I think it's really important to think about it in the context of a specific disease state, in this case, atrial fibrillation. So in terms of the social network, the lack of connectedness, perhaps lack of access to, comfort with digital health tools, social integration, and caregiver support all contribute to differential outcomes from a social determinant perspective. Structural racism, which is an important topic in and of itself, when we think about underserved populations, bias, discrimination, issues that impact on access to healthcare and the patient's perception of quality healthcare, access to specialty healthcare. As we will learn, we talk about the atrial fibrillation paradox, perhaps understudied pathophysiology, even residential segregation, which can contribute to lack of access overall and lack of access to the appropriate specialist. Going around the table, financial resources that the patient can bring to bear to receive appropriate care. Also access to clinical trials, an area that Dr. Ferdinand is so expert in discussing, and high rates of chronic risk factors. So these patients often have multiple other conditions along with their atrial fibrillation. Additional social determinants include rurality and neighborhood. And it's important to mention rurality because this is not, if you will, just an urban kind of populational issue. It's the social determinant of our patients who live far away from healthcare providers. and how they're able to connect with providers and get the same level of care. Environmental pollution may play a role contributing to other healthcare conditions, transportation, etc. And finally, very importantly, health literacy. Thinking about our case and the patient understanding perhaps how to take the various oral anticoagulants, whether it's warfarin or a DOAC, medication interactions, lots of issues that impact on patients' adherence and compliance, both with prescribed therapy, follow-up appointments, and appropriate testing. So race and ethnicity is certainly important to put right out there as a key driver of healthcare disparity. Influences of perceived bias and discrimination go well beyond medical care. These inequities are described in pretty much every disease state, also in cardiovascular disease, including atrial fibrillation. We know, unfortunately, that despite lots of access to healthcare, African Americans have a 20% higher death rate from cardiovascular disease, and therefore race and ethnicity may influence atrial fibrillation recognition, management, and outcomes. There is a preponderance of clinical risk factors in atrial fibrillation. We often use the term in younger people of lone AFib. This is definitely not lone AFib. These are patients who have concomitant conditions such as hypertension, diabetes, sleep apnea, obesity, and these conditions are seen in greater numbers or greater percentages in patients from underrepresented backgrounds. Interestingly, as we'll talk more about, there are lower rates of atrial fibrillation in some of these populations, but a higher degree relative to the rates of AFib of complications. This has been seen in a number of studies, including the ARIC study, ARIC. The lifetime risk of developing AFib is lower in African Americans actually than whites by a pretty significant percentage. So this is some of the data showing that the AFib diagnosis by race and ethnicity is lower in non-whites. So we should be out of the woods, right? Well, we're not. There are many issues that interplay with this. We don't fully understand this paradox. It may have to do with various biases that may influence these results. And as I mentioned, although there are lower incidence of diagnosis, relatively speaking, there's a greater rate of complications. So this is looking at 4 groups: non-Hispanic whites, Chinese individuals, Chinese background, non-Hispanic blacks, and Hispanics. And we see a fairly common pattern that age is an important driver for AFib incidence. So certainly, just like hypertension and other forms of cardiovascular disease, age is an important driver of disease in all populations. I already talked about prevalence that is perhaps underrepresented in minority populations. This is that paradox that we don't yet fully understand. However, awareness of AFib is a real issue. This gets back to that social determinant related to literacy. And as you see on the bottom bullets, participant awareness of AFib in one study was only 1/3 of that of white participants. The MESA study published recently actually found similar rates of atrial fibrillation, I'll call them, around all racial and ethnic groups. So perhaps if we do a better job, a deeper dive looking for atrial fibrillation, that paradox is not as wide as may have previously thought. AFib differential clinical recognition by providers may explain some of these differences rather than biologic or genetic differences. Underdiagnosis of AFib and lower receipt of guideline-based therapies is a problem. We need to appreciate that, again, for various social determinant reasons, African American and underrepresented patients may not receive the same guideline-based care as majority populations, and therefore this can lead to greater rates of complications such as stroke, as was seen in the ARIC study, stroke and death. I think you'll see the directional difference and racial differences in AFib-associated cardiovascular disease and mortality, consistently higher in blacks than whites. A cohort study to assess the efficacy of warfarin based on using registry data showed rates of stroke, again, highest in Black Americans as compared to 2 other group studies, Hispanics and whites. Whether this is inadequate dosing, lacking connecting with the patient and ongoing adherence, maybe some factors we don't yet understand, but just getting patients who we think are on doses, we still see significant differences in outcomes. There is an increased prevalence of risk factors. There's decreased awareness and detection of atrial fibrillation. There are decreases in treatment, whether it is guideline-based treatment, and all of this contributes to increase in atrial fibrillation complications. So we've talked a couple of times about this atrial fibrillation or AFib paradox. What are some possible explanations? It may be limited ascertainment due to structural racism, less access to participation, etc. It may be higher incidence and prevalence in whites, so just higher rates. There may be some things we don't know. There may be premature death by race and ethnicity. This could explain some differential exposure to risk factors, or some traditional risk factors may be more common in race and ethnic groups underrepresented in medicine. Or I would add to this something yet unknown that future research will delineate for us. Thank you so much, everybody. I look forward to our question and answer, and I'm going to turn it back over to Laura.
Thank you, Dr. Kountz, for that wonderful presentation, in particular, really looking at that AFib paradox. Well, we're going to dive deeper into social determinants of health affecting non-valvular atrial fibrillation management, and what are some strategies we can do to address this?
Thank you so much, Dr. Kountz, and thank you to the listeners for joining us. Up next in Podcast 2, Laura Ross is going to dive deeper into social determinants of health that impact NVAF, and will provide specific strategies to help address these. As a reminder, to view the full program and to join the discussion, please visit pce.is/NVAF. As always, thank you for listening.